Okay, we're going to get started. Thank you, everybody, for joining. I'm Robin Shapiro. I'm the Washington State Health Advocacy Association, or WASHAA, Board Chair. Delighted to see so many people joining us today. We are hosting this free community conversation about health advocacy in the time of COVID-19 in order to really educate people and also provide answers to a lot of questions. There's a lot of information floating out there. And so really our conversation today will be focused on health advocacy type questions. If this is something that you will be finding valuable, we're happy to host additional conversations in the future. And so all feedback is very, very welcome. As we're getting started here, I want to just encourage you to use the chat function to ask questions, or also send them to info@washa.org. And I'm delighted to kick off this conversation today with Dr. Dale Reisner, who is the Medical Director, OBGYN of Safety and Quality and Safety at Swedish Health Services. And she's first of all, we just want to say thank you, Dale, to you and all of your colleagues for really protecting us and for also making yourself available today to answer questions and give us an overview of what is happening here in our state and with our healthcare system. So with that, I'm going to put myself on mute, and Dale, if you can go ahead and give us an update, and then we'll take questions after that. Thank you.
Sure. So, hello, everyone. I'm really thrilled to be here. I have participated in WASHA for at least 5 years, actually a little bit before that, but on the board for that length of time. And I'm a huge advocate for advocacy with healthcare. It's something that I've always actually done personally with patient care in the past. So I have the background of being a high-risk obstetric specialist, but have in the course of the last 7 years now been involved in quality and safety across the Swedish system in obstetrics and gynecology. And as COVID has begun, I've kind of inadvertently become quite well versed in a lot of aspects of COVID that don't touch OB either. So I will speak to what we do know about COVID and about interactions, both in your personal life and in a hospital or clinic setting. And very, very open to questions, and then kind of talk about where we're at in the state of Washington, and where there is some hope and where some good things have happened. So that's kind of the items I'm gonna touch on. The background is that COVID probably has been around since late last fall. Certainly there were early cases in December that were not advertised as such, and by some countries trying to keep things under control within their own country and not necessarily letting the whole world know, we've had a spread that probably is worse than it had to be totally. This is pretty typical of human behavior no matter what country you live in. It's also typical of what we've done in the United States. So we're really behind. This is a personal comment on my behalf. We have underfunded or defunded many of the public health institutions across the country over the course of years. And we have also defunded the epidemic function of the CDC in the last 4 or 5 years. And that has left us far behind where we should have been in preparedness once we knew this was epidemic in a variety of countries. So because I'm mentioning that because we started out incredibly behind in not having the ability to screen people. And when we did have screening tests, they have taken a really long time to come back because we've overwhelmed the labs that have them. What is good is that in the past month, in the state of Washington, because I thought it was unfortunate, but it might actually have been fortunate that we were the first epicenter in the country, because we have really mobilized all of the preventative approaches, and we've got a lot of innovation that has happened in Washington State that the rest of the country is taking advantage of. And because of, will probably peak sooner and taper off sooner than most of the rest of the country. So that is kind of good news in a bad situation. The University of Washington has created its own in-house testing, and they have drive-through testing for their symptomatic patients and their staff. They've had that for quite a while. They have improved their testing so that they can get quick turnaround time for people in their system, but that's not necessarily available to everybody else in the state. There are commercial labs that have also mobilized. In the Swedish system, we have used whatever lab will give us the quickest turnaround, and I'm not sure if other hospitals are doing that. And the Swedish system includes Edmonds Campus, Issaquah, Cherry Hill, which is specialty for cardiac and neuro, First Hill, and Ballard, just so you know when I'm talking about the system. And I am really referring to all types of care providers and patient medical issues. So we have utilized both the University of Washington for our results. We had in the past a turnaround time of 24 hours. That was the quickest. And we are now getting tests back through LabCorp, which actually—
Yo, what the fuck?
I'm sorry? I don't know what's going on here. Are we still connected, Robin? Do you know? Robin?
Yes, we are still connected. Go ahead.
Great, sorry. So we now have internally in the Swedish system turnaround time that's about 12 hours. So I'll keep talking. Well,
Yeah.
maybe Rob find out what's going on here.
Yeah.
Yes, and so the ability to test really has a huge impact on how we manage this pandemic. The rapid turnaround, or if we have a super rapid turnaround, allows us to assess somebody right away and to know who may be asymptomatic or mildly symptomatic and infected. And those people then can be treated, whether it's treatment at home or treatment in an alternate facility.
Sorry, Dan, I have a question.
Or in a hospital.
Sorry.
Yeah.
Yeah.
Michael, can get this word? Yeah. Hey, looking at the birthday shit. Oh, that's my.
Sorry.
Yeah. It's hard to mute everybody.
Yeah.
I think.
Yeah. Yeah.
Robin, that's a troll. Do you that we have a troll? Like,
Yeah. I
clearly.
just removed them. I just.
Okay, awesome. I'm like, that's
Sorry
not
about
an error.
that.
Okay, thanks.
Sorry about that.
Of course, there would be a troll.
Oh wait, troll.
Okay.
Oh, hey, ladies.
We might need to start over, Robin. Do you think? Do you think if we switch gears?
We will remove. Oop. Wow. Okay.
Go away.
Bizarre. I don't know. Okay. Okay. Let's continue. That was bizarre. Okay.
Yeah.
Sorry
Okay.
about that, everybody.
Yeah, we'll get going. So, so really, the point of that last little bit was that we have a much better ability to minimize contact risk, and then potentially at some point, and I'm not saying in the next 2 weeks, but as we have fewer infections, as we may have other options available for where we treat COVID positive patients, we will not have the group of patients that we are needing to test and take a long time and treating as if possibly infected. That takes a lot of protective equipment and staff time and physical resources to separate them from others. And so we were able to really focus on the people that are really sick, and those of you out there who are not infected, and you'll know exactly your situation. Having said that, we know that Abbott Labs is creating a new test that will give us a positive result within about 5 minutes and a negative within 13 minutes. So within 15 minutes, we would know one way or the other. And that initially, when it gets rolled out, of course, will be in high risk areas. It won't be available to the general public right away because they're not going to be able to make that many tests right off the bat. But it will be point of care testing, so we don't have to send it anywhere. And we'll get trained how to use it. And it will really, really decrease your risk if you do need to come to the hospital of being exposed to someone with COVID unknowingly. It will improve our ability for us to keep our staff members functioning and healthy as well.
Dale, we do have a question about the testing, specifically about when it might become more prevalent and available to the general public.
Yeah. So right now, the recommendations for screening have gotten a little muddy. Depending on where you are, the majority of people are still getting screened if they have a fever greater than 100 or 100.4, cough and shortness of breath, and possibly GI symptoms. We do know that is really not picking up, that's picking up the sicker patients, but it's not really picking up someone who has no symptoms or has mild symptoms. And we're starting to see cases in the obstetric arena where a pregnant woman would come in, absolutely no symptoms, no known contact, go through labor and or have a cesarean section or a vaginal delivery, and then develop symptoms. And that makes sense because both having a baby, whatever way you do it, is a stressor on our bodies. But it is scaring people, of course. And if we are able to screen that woman when she comes in labor, we would know right away. We could use the appropriate protective equipment, and we could be alert for potential deterioration based on COVID. So you will still see pockets where screening is liberalized, but not liberalized to the general population. And it will be stepwise. And I can't really give you a time frame for that.
Yeah.
Yeah.
Okay. So we do have, do you want to give any other overviews, or do we want to start taking some questions?
The only other overview I'll give is that I mentioned maybe in some ways it's good we were early in the COVID epidemic and that we got on top of things right away. We have, irrespective of how you feel about Governor Inslee on other things, he has done a fabulous job with directing people in the state to stay home, closing businesses, sad as that is, at an appropriate time, all of those things. So we really believe, looking at other major viral syndromes and the protection of social distancing, that we're ahead of the game for the social distancing restrictions that have been put into place. We were initially in the Swedish system doubling our COVID positive patient cases every 3 to 5 days, and then it stretched to 5 days, and now it's at 6 days. So we know we're plateauing a little bit. We are expecting a surge or peak in the next probably 2 to 3 weeks. There are a couple of predictive models out there, and we can show you what that looks like for the state of Washington.
If you want, what I can do is I'll share my screen real quickly here.
And you guys may have questions about that as well.
Let me go ahead and do that. Hang on one second. And can you guys see my screen?
Mm-hmm.
Okay.
Screen's up.
Let's
Ooh,
just
that's
pull. Okay, let's just pull this up, which is what you wanted people to see, right, Dale?
Yep.
So this is, we're happy to send around this link, but it basically looks at hospital use and resources. And I
Yes.
think it should give us a little bit of comfort. Is that what you're going to tell us, Dale?
Yep. So this is Washington State, and it's a predictive model that a research area at the University of Washington has created. We also, within the Swedish and Providence system, have some predictive modeling that actually mirrors this very closely. So looking at our COVID, and this, when you, if you're interested in looking at this, you can look at all states, any one state that you have loved ones in, or that you're just interested in, and you can look at the whole country. So what we know is that at the peak, we think we will need over 3,000 beds across the state of Washington, and we have plenty of beds available. There may be pockets where they run out of beds, intensive care unit beds or whatever, and those places through partnership with many of the larger organizations across the state, of course, would be able to be transferred to a place that has higher beds are thought to be probably 100 beds short. And that's actually not a huge problem, because even in the Swedish system, we have OR space that we're already converting to ICU beds that we're not using, because we've actually ceased all elective surgical cases, and we've done that for several weeks now. So that's the good news. And then again, I think we were on top of ordering them when we really early in the game realized we were not going to have enough. And so we think that from a statewide perspective, you might need to leave your hometown, but the care you need would be available.
Yeah, and so we have a couple questions that have come in related to testing. So for instance, people want to understand if there's going to be a test to tell whether asymptomatic people have had the virus before.
Great question. In February, I came back from a conference in Dallas area, and 3 days later, I got really sick with something that seemed viral. I thought I had the flu. Then I got pneumonia. I have no idea. It probably was the flu, because all of our early rule outs for COVID in our OB patients were either not coming through with any kind of known virus, or were COVID negative, or were influenza A or B. And we know that this year the flu, which is a dangerous viral infection as well, the virus mutated quickly, and so the vaccines are only partially protective. So yeah, I would love to know if I have antibodies against COVID, because I could go in and donate my blood towards vaccine formation. So that would be helpful for those of us that are sort of scientifically oriented. For the rest of you, that would allow you actually, once we got to a point where that was vetted, that might allow you to go back to work. That it might allow you to go volunteer. There, that would open horizons for those of us who have already had the disease but didn't know it, or had very mild symptoms, and weren't highly suspected to have it. We know for sure there are many more people asymptomatic or with mild symptoms that might be consistent with what they think is their allergies, because it's spring, and that have been infected with the virus.
So I have another question that came in from a healthcare person, and it says, when a person is COVID positive and they're contagious, are they? Here's the question: when a person has been COVID positive, they've tested positive, and after their symptoms have resolved, except for no taste and smell, are they contagious? can they spread COVID after their symptoms have resolved, except for no taste or smell?
We don't know. So there have, for sure, they should be considered contagious for at least 14 days. The no taste or smell are things that, so that's probably an effect on the nerves that help us to function with taste and smell. And so that may not be necessarily associated with being contagious. There have been reports of the contagious, suspected contagion up to 3 weeks. I've not seen anything beyond that. And there's some misinformation probably on the cruise ship. So you may have heard the cruise ship was reported to have evidence of virus long after people were off. And it is thought that those were viral DNA particles, not active virus. So there's a lot of fear, and there's a lot of information that needs to be put into context, I guess is the best way to say it, about all of that.
And let me just clarify there. So you're saying that 14 days to 3 weeks after you are no longer symptomatic.
14 days from diagnosis.
From diagnosis, not symptomatic.
Symptom resolution, probably you should consider a week after that, because most symptoms are not, again, we don't know about the mildly affected. We really don't understand how long they might be infectious. But someone who was sick enough to get tested in the first place, by the time their symptoms resolve, because the cough doesn't go away quickly, I would consider at least a week after that, or a full, 2 to 3 weeks if it's someone that you need to be around.
After the cough goes away, right?
From symptoms to symptom end to being considered infectious, I would add a week to that. So
yeah, great. That's great. That's very clear. Yeah. And similarly, we have this question coming in during lockdown. There's obviously going to be necessary movement and among families. For instance, hearing of kids who've lost their jobs and are now required to move home. And testing would be important when it's available, but I thought you had some really good points the other day about, what people should be doing if they don't know if they're contagious and they're entering into a new environment. What should be done? Yeah.
Right. Yes. So there is so much confusion about masking and whether masking will protect you. Masking from the scientific perspective, there is some confusion about whether me masking myself when I go to the grocery store is going to protect me at all. It probably won't. Good hand washing does. Being appropriate, that you wash down surfaces and things like that. Like I got a pair of rubber gloves that I sanitize before I go in, I gather up my stuff, I pay the thing, I come back to my car, I take them off inside out, and then they get sanitized afterwards. So those kinds of things, if you're not using gloves, the wipes, if you can find them, the hand gel, if you can find it, pre and post everything you do. And really trying so hard not to touch your face unless your hands have just been cleansed.
Oh. Dale, we lost your video. We lost your video.
Okay, there we go.
Okay, great.
Yeah, my phone is supposed to be totally off, so I don't know what happened.
Yeah.
The other thing about that is if you have somebody that's mildly symptomatic who is at home with you and they're coming into a common space like the kitchen and not staying in a room, that kind of thing, have them wear a mask, because that way if they are coughing or sneezing or whatever, then they are keeping that from getting into the room. There's also confusion about how you catch it. So it is not, the cough is not that the virus gets into the air automatically. If you are within probably 3 feet of someone who coughs, perhaps you can get small droplets on you. It's a droplet exposed type of infection. So really important that you wash down all the counters in your house when you're with, multiple family members, and do that way more frequently than you would. So any surfaces that could be exposed to that person coming into that area will help you to stay, as virus-free as possible.
And I had a question. So somewhere I read, this is probably a rumor, probably a myth, that the droplets can hang in the air for a certain amount of time. So like if you're out walking
Yeah.
and somebody has coughed in front of you, you're not going to get it.
Yeah. You would have to be like right next to them, which
Okay.
if you're running, you're not supposed to be. Yeah. They actually don't hang in the air for very long. It's very interesting to me that depending on what surface they land on, like most viruses, they don't stay for very long. If they land on, metal or porcelain or something like that, that is not a friendly surface, but they can live longer, at least. I mean, they're not sort of living things in and of themselves. They take advantage of your living cells, but they can be transmissible on cardboard for a lot longer. So, your packages that get delivered, you want to pick up with gloves, you open them, get your stuff out, because a lot of people are getting things shipped to them now, right? So if you were worried about any surface, I would be more worried about cardboard than anything else. And, you can't wipe that down as well. I guess you could give it a try.
I have heard people have who get cardboard packages. I don't know if this is helpful or not, but they actually have them outside and basically quarantine the cardboard for 2 days before bringing it into their house. I don't know if that's scientifically appropriate or if it helps or not, but
I don't know. The length of time I read about recently for cardboard is actually much longer. It's like weeks. So I would put it outside, empty it, get your stuff out, and just leave the cardboard outside in a spot, and you can, contain it, start containing it in a location till a decent amount of time.
Good idea.
And you can search that if that gets updated.
So we have a good question here from Deborah Everson. For discharge purposes for elders needing to go into community care after a diagnosis of COVID-19, the CDC recommends either 2 negative tests for 72 hours after fever and symptoms have abated. Is that enough? Should these folks be further quarantined in the new environment for an additional length of time? And I think that speaks to what you just said. Let me see if I heard that correctly, that you think it would be a good idea for people to be quarantining for about a week after their symptoms resolve.
Well, that's when you are not able to test. So the 2 negative tests should be sufficient. There are some false negatives, but it would be incredibly unlikely to have 2 false negatives. So if they are getting 2 negatives, which I think most places are doing with sicker elderly patients that are especially going to community living, then I think that's valid to go ahead and feel comfortable with that.
Great. So, and somebody asked for you to repeat again, for clarity, the part about 14 days and 1 week. And so could you repeat that? Because I think people might not have heard it.
So what we think so far, and again, we are missing a ton of information about how long someone who's asymptomatic could shed. What we think so far is if you get symptomatic, you were able to transmit the day before that you get your symptoms. And so from then through at least 14 days, we would anticipate you would be shedding. And it could be as much as 20 days. So I'm just saying a week after that. You should be symptom-free. So it's really challenging with people who have the chronic cough or who have other symptoms that have cough or sniffles associated, because you scare people. And we don't have enough tests to really right now know if it's ever seen longer than 3 weeks from onset of symptoms. So I think 3 weeks from onset of symptoms, if you don't have the ability to test. If you have the ability to test, like for the sicker people, we are testing before they're going places, then 2 negatives should be sufficient.
Okay.
Yeah.
So this also came in a little while ago, which was more countries have bent the curve using universal mask policies. Why aren't we following what's worked elsewhere?
Can't hear you.
Oh, so let me ask
There you
that
go.
again. Okay.
Yeah.
So more countries have bent the curve using universal mask policies. Why aren't we following what's worked elsewhere?
Well, we don't know actually that universal masking is what did the read if you read on every single prior pandemic that has occurred with viral infection or even the bubonic plague, the social distancing is what does it, not masking. And so because if you are around something that is airborne transmission, yes, masking would work. But this is not airborne, it's droplet. And so it's really this rigid hand washing and keeping things clean and the social distancing that that all of the countries that have, so China's decreased their transmission. They've actually had days where they had no positive cases, and they attribute it totally to social distancing and the mandatory. Italy is starting to see a downward trend. So that is the problem. And in those countries, part of the reason things got out of control so quickly, and part of why New York has such a huge problem in our country, is it's challenging social distance when they have multi-layer family members. Why we see the high elderly death rates, little tiny children, 3 generations that live in one small home or apartment. And so how do you social distance that? So it's really this, and yes, you would wear a mask in that situation if everybody in the family, is around in one spot and you can't move.
Yeah.
We have the luxury in our country, in most places, to be able to spread out.
Yeah.
And
So
that,
we have the same question from 2 different people, which is, can you explain the difference between airborne and droplet? It sounds like a sneeze can infect, but that's not airborne.
correct. So a sneeze will, and a cough will knock out particles that are relatively large compared to things that are airborne. So without getting into too many details about how many microns those are, it's the fact that those droplets are in the immediate vicinity of the person who just coughed or sneezed, who was infected, or got on their hands. So one of the things that has come out of all of this COVID information is people looking at influenza, which we're used to, and looking at the biggest source of transmission for influenza are food handlers. So it's all about touching your face, being right in front of somebody. Of course, you may be exposed, and that's when a mask might help you. And if you feel better wearing a mask, you can wear a mask. I would not count that that's really what's protecting you. I would not want people to feel like that was more important or even equally as important as the hand washing. So washing, if you can't get the gel, the washing for 20 seconds with soap, rubbing actually, you know, drying with a paper towel is probably better than with the air dryers, because you kind of slough off anything that's on your skin better with the friction of paper towel or cloth in your own home. So so that's where the difference is. When we have a COVID positive patient, their aerosolization, which are tiny particles, only happen if we have to intubate, if we have someone with asthma that needs nebulizer therapy, if we're doing any kind of ventilator suctioning or that kind of thing. So it's challenging for us to just have it in the air around us unless those types of procedures are happening.
Mm-hmm. That is good. And somebody, so Iodoka has recommended a resource that I will send around after our conversation. So that talks a little bit about that too. So thanks so much, Io.
Yeah. I did want to just add one thing that, because I think I didn't really answer that, the what if you have been exposed blood test. People are actually actively working on that, and people are working on vaccine, and there are several therapeutic, big therapeutic studies going on in the country, looking at antiviral medications in particular. And there is a lot of mystique and miscommunication about the use of hydroxychloroquine for treating this virus. Sadly, physicians wrote for their family members and, you know, friends and things like that. So we now have a shortage of that drug, which is used for other people who are immunocompromised. So this. So not every lupus patient will be on hydrochloroquine, but it's a pretty common drug. And so now we have shortages of that. There is no data. There was a small study that said maybe it would help COVID, but when you look at other similar coronaviruses, SARS, MERS, some of the ones that we've seen in the past, it had stabilized and never been shown to be of benefit. So we now have people in the community who are scared, who have realized that their fish tank cleaner has chloroquine in it and are ingesting that and are becoming deathly ill. So really think about the science behind this. Don't try to self-medicate, for sure. Try to protect yourself from getting it in the first place. And if you do have significant symptoms, of course, let people know. And as we have testing available, more rapid and more available, we will be able to broaden it to either asymptomatic folks who are being exposed to that symptoms. So just wanted to mention all of those things.
Yeah, that's great. So I have a few other questions that have come in. One is from Sean D'Amelio, who wanted you to comment about, should people be around people at home who are using a nebulizer? So somebody who obviously has breathing issues, and is it a higher risk?
The handheld nebulizers that we have at home are not going to generate that aerosolization in the way that the nebulizer treatments that respiratory therapy does. So if somebody is got severe lung disease and has somebody coming in doing those deeper nebulizer treatments, yes, I would be concerned. And when those things happen, just so you know, in the air, anything that's aerosolized is gone within about 30 minutes.
30 minutes.
About 30 minutes. If you have in and out in that room or drafts or any of that kind of stuff, that will cause it to swirl and it would last longer. But the nebulizers that we have for use at home, that are the little handheld ones, inhalers and things, those should not generate anything that you would need to be worried about.
So I have another question here from Deborah Everson. What is the current information about fecal transport of COVID-19? And obviously this would be very important for caregivers who are cleaning up after people at home.
Yeah. I haven't seen anything about fecal transport. I would assume it's probably there. We know some people are having GI symptoms, not necessarily caused by the COVID, but probably because they're sick.
Mhm.
And so I've not seen anything specifically to feces. It does not appear in amniotic fluid in pregnancy. It may well be in vaginal secretions. It may well be in blood. You know, I think that we have to assume that someone who's sick has it in all of those things that
Mhm.
they excrete.
Mhm.
But what you would need to do for that is simple hand washing, gloves, all the protective stuff you would normally do when you're handling somebody else's bodily fluids.
So I just want to pass along some gratitude from people who are on the call. This specific
Yeah.
piece of gratitude for you is just that you're doing a wonderful job answering all of our questions. We know that this is a really such a busy time, so we're really grateful for you taking time out. I'm not ending the call yet, but I just wanted to pass along a little bit of love to you. And
Yeah.
so it says, please deliver my gratitude to her for her patience and shared knowledge. It's a real blessing.
Oh,
So
oh, yes,
thank
yes.
you. Thank you so much, and so much for your time. We're not ending. I just wanted
Yeah.
to that came in. So another question here that we got into info@washa.org is we're getting a lot of questions about how to handle groceries and takeout containers because more
Mhm.
people are thinking about that, right?
Yeah.
And so the questions are wipe them down, wash hands, don't touch face. There's a video going around of a doctor teaching people a modified sterile technique for handling groceries and takeout. It is causing a lot of worry. And I
Yeah.
think there's generally a lot of worry in general. And so, what do you recommend and what's reasonable? People are kind of going to the nth degree. What is
Right.
most important?
Right. Well, I would say that I would wipe down the outside of the containers. I would not be afraid of that food. I would eat it happily.
Yeah.
I haven't done any of that, run over and pick it up. But let me tell you, I'm starting to go a little stir crazy with what I'm making myself. So, and I'm just me hiding out so my children won't come around me. That's fine. But my dog and I, yeah. Um, so, um, so yeah, I have heard people say maybe when it comes to berries to use
Ah,
frozen berries
ah,
if you're cooking or eating, and those should be fine. I don't because I think it's harder for things like berries to be comfortable that you're cleaning them, and plain water isn't going to do the trick. So.
mhm.
Um, and I don't think they taste very good with soap on them. So, yeah. But otherwise, and you have things like bananas you can, peel.
Right.
I personally am not that worried about
Uh-huh.
that. And
Yeah.
I do feel like, um, it, I'm disappointed in some of my colleagues for some of the myths that they're promoting, such as the chloroquine therapy stuff. And um, and we need to be reasonable about this. In many respects, this is very much like the flu. So
Mhm.
when we're having flu season, we're not freaking out about our vegetables in the way we are now. And what isn't the same is that because it's novel, it's new, we don't have vaccines out there. We don't have herd immunity. And really
And can you
yeah,
just explain, some people might not understand what herd immunity means. Could you
yeah,
explain that simply? Mhm.
yeah. So vaccinations have uh, cured or almost cured many horrible diseases. Polio is a great example, right? So we got polio vaccines. Used to be, you were exposed to polio, there was nothing you could do about it. We knew very little about transmission and all of those things. It was not nearly as virulent as what we're talking about with COVID-19. But with vaccination and with the bulk of the population agreeing to and having that vaccination, we have almost annihilated. We actually had been close to annihilation of polio. We've seen a resurgence with people as greater percentage of the population declines vaccination. We will see things come back like smallpox, polio, things like that. So herd immunity is really, you know, we're mammals. Most of us are protected. Then there are very few people who can get sick and very few people who can transmit. And so when that's the case, then the risk of the disease is very, very low. So when we get a vaccine for this, it won't be perfect probably, but it will. So right now, what we see is that the researchers that are looking for those antibodies for past, you know, I was sick, I have antibodies, and so I know I had COVID. Those people feel like for the COVID that's going around right now will be protected and not get reinfected. We do not know whether COVID could come around next year and be the same or be kind of like the flu, where you could do a vaccine that will minimize the disease if you do get it. So I think that it's not in the same family as the flu, but the behavior and the kind of range of how it expresses itself is similar.
So we had a question about whether or not it's necessary to clean the bottom of your shoes if you've taken a walk outside.
It shouldn't be. I mean, and
any more than normal.
Yeah, dirt on your rug.
Yeah. So that's, let me see if I have any other questions while we're waiting here. It's important also that we hear from you, the people who are on the phone, what you would like WASHA to be putting together for you. So we've talked about offering periodic conversations like the one we're having with Dale Reisner today to help you and your families and the people that you work with understand how to address virus and health advocacy also along the way. One of the things that came up on our professional call that we did last week was clients are asking questions about, if they're delayed in having their doctor appointments, and now with the ability to do telehealth, some providers are or are not able to do that easily. And so sometimes it's a matter of asking. So Dale, can you address in the current environment, since it's kind of changing and it's a little bit different among providers and hospital systems, what's the best approach to ask for the care that you want? And what's the kind of short-term impact on patients who are having to reschedule appointments and things like that?
I'm losing you. Yeah, I lost that. But so you were probably asking about patients who have chronic illnesses that still need care. Is that correct? Okay. Yes. So most of those people are in a healthcare system of some sort. Got all these consolidated systems, at least in Washington State. And so each of those systems should have virtual access for you. If you are sick, so for instance, with our obstetric patients, we have, which is, you could look at pregnancy as a chronic illness for 10 months, I guess. We have higher risk patients that are still seeing and being protective with. We have lower risk patients that we are doing virtual visits or phone visits. And so we're spacing out when we see them and seeing them at more critical times during the course of their pregnancy. And that goes for other chronic diseases. So, chronic disease that's well managed that you would normally see your provider every 3 months for a check or something like that. You probably don't need to see them at 3 months. You can check in with them and they can check in with you. A busy internal medicine practice might not reach out to you. So if you are concerned, I would say, give them a phone call and see. Doctors' offices are open they're very limited, and they are seeing the sicker patients and the more, urgent issues. But the people with chronic medical conditions should not be left out. So at least contact virtually or otherwise. Swedish has a virtual express clinic that I did clarify is to anyone, even if you're not a current Swedish patient. I also know that Polyclinic has some express clinics set up, and has some drive-through type testing for sick patients. Swedish also has that for our own patients and our caregivers who are experiencing symptoms. All of those require an appointment. So it's a phone call into the system to say, I think I need to get screened. And it's great to use those resources in that way, because as we can open up screening to milder symptoms, I think it'll be really important to still be able to drive through and, get your nose swabbed, which is not a common thing, and go home and get your result later kind of thing.
But the important thing is to call in advance, right?
And set up an appointment. For those with chronic illness, for sure, you contact your primary care provider or your specialist, if it's a rheumatologist or it's an endocrinologist, or hematologist, you contact that office and say, I'm concerned that I'm not being seen, and have a conversation, whether it could be a virtual visit or otherwise. Telemedicine has been opened up dramatically in the places that have availability already set up to reach out to people in unique ways. And Congress nationally finally and in our state has said, we will reimburse at par, which was not the case before. So a lot of systems are scrambling to expand their telemedicine opportunities for patient contact as well.
Yeah. So we have a whole bunch of questions. We might not get to all of your questions, by the way, people out there, but maybe that's something that we can follow up offline. But I do have a question here from Julie Forkesty, who is a geriatric care manager, aging life care manager. And she has a question about client needing electric shock therapy, being told that she can't have them right now, cancer patients who can't have their necessary surgeries, which are really important. They're being held off right now. So there's probably no good answer to these questions, but how can advocates and family members address that or frame that?
I think that's a great place for advocacy and for understanding what is necessary versus what is optional.
Yeah.
It's tough. It's really tough. So for cancer therapy, for instance, yes, we are still providing cancer therapy to patients. However, if it's something where an every 3-month process is not, could be stretched out and wouldn't really impact your response to therapy, that is what's happening. Yeah. So I think for the patient may not understand that because it's scary to have cancer. You're wedded to what your game does. Yeah. So I think that's a great place for the advocate to really be able to help say, okay, what's the downside of this? Is there one? And how do I reassure my client that this is okay for now? And if it's not okay, and there have been impediments that were artificially put up, by somebody who meant well, but, didn't really get it, I think that needs to be then revisited. So we are not doing elective surgeries. That doesn't mean that we're only doing surgeries on people that, are bleeding to death. So there are surgeries that, if delayed, same thing with orthopedic things, if delayed, would have a major impact on the patient's well-being. Those are also still being done. So that should be the message.
Yeah, very good. And I have a reminder here from Karen Vogel, who focuses on insurance and expense advocacy, to remind people to document all interactions with healthcare providers in case mystery bills show up later, and don't assume the detail will be available. So it's very important, either working with an advocate or not, that you're keeping track of that information and to share that with clients and family members. And there is a question about how to connect with advocates during
Yeah.
this time, should that be needed. And so, of course, WASHA has a directory. If you go onto www.washa.org and go under Find a Health Advocate, you can find that. There's Greater National Advocates, gnanow.org. And so now's a really good time actually for people to connect with advocates virtually to try to get their ducks in an order. There's also a comment about are more conversations happening about end of life wishes to focus on
Mhm.
anxiety. And I know that Bonnie Bazell, who's with Honoring Choices Northwest, who is on the line. But I don't think, I think she's on listen only mode. That's a very good resource for people to take a look at, as well as Bannister Advisors also has a free resource about getting your ducks in order. So there's a lot of really good resources out there that we, WASHA, will be sending around after this call and make available to the public. Maggie Pheasant asked about, could you say a little bit more about documentation? And I think what we would say to that is make sure you're writing down telemedicine, phone calls, emails. Oh, and Bonnie Bazell actually just raised her hand. So Bonnie, why don't you jump in here? Are you there? There you
Yes,
are.
I am. Can you hear me?
Yes.
Okay, great. With documentation, definitely go to honoringchoicespnw.org. You can find a lot of information there. You can also connect with us, and we're happy to help with virtual sessions. So if anyone you know needs help talking about values and preferences around healthcare, we're happy to do that one-on-one. We can lead group sessions if like a family wants to get together and talk that through. So we have a connect page right off of our website that you can just shoot an email from. In fact, there's also a pre-filled email if you want to share it with your loved ones and people who matter in your life, so that you can say, I want to talk about this. But feel free, and Robin, feel free to shoot my email out to everyone so they can just reach out to me directly if they prefer.
Will do. And also wanted to also mention a great resource and WASHA partner, finalroadmap.com, which we will include in our resource list. They are fantastic in virtually keeping track and writing down and facilitating people writing down their wishes. I want to get one quick, interesting and different question in, which is, this comes from Jennifer Kropak. When someone dies of COVID-19, are they still infectious? Funeral directors are wanting PPE, so the personal protective gear similar to healthcare workers. Why?
Well, they should, we don't know. And I would assume that if they die with active COVID disease, that their bodily fluids may contain the virus. So I think it's reasonable for them. I think they have a lot of, I mean, they don't just handle things in their normal street clothes. So they should have gowns and gloves anyway. And yes, they could wear a mask, but that person's, you know, it's mostly going to be contact stuff. So for sure, gloves and some kind of a gown, cover gown, would be appropriate for them. I know there's been some, probably not so much in this country, but certainly sadly in Italy, horrible situations with loved ones not getting the post-death care that the family knows that they, patient would have wanted, the person would have wanted, and that they would have wanted. But I feel like that's not such a big problem here. I do want to add one thing to Karen Vogel's comments that I think is super important with you document your visits. We have been assured by the healthcare authority for Medicaid beneficiaries that if they have expanded coverage for something during this pandemic, that they will cover the things that they've said they will cover. However, their systems are built to deny. And so if it's an example I can give you is I got them to ensure that babies that were discharged to home that needed that were candidates for home bilirubin therapy would be covered by every single one of their insurance companies, and it's been spotty in the past. And what they said is, you could get a denial initially, send it back, and be patient with us, because the people that work on that stuff, you know, are overwhelmed just like all the rest of us are. So the same would go, I would say, for your private insurance companies, co-pays, all those things that we've been told either federally or in the state would be covered or limited. If you're getting bills for those things that you feel are in error, don't get mad, be patient, but don't give up.
Yeah, great. So we are at time, and we there are several other questions, and we will seek to answer them. I just want to say a big thank you to Dale Reisner, who is medical director at Swedish Health Services for OBGYN. You're getting a lot of claps online, Dale, and you've just been so generous with your time. And we're hoping that we might be able to host another call next Monday at 10 a.m. If you have specific questions or topics that you would like to see answered, in addition to what Dale has provided today, please just let us know at info@washa.org. Really appreciate you sticking with us today, and let us know how WASHA can support and be of help. Thanks again, and talk soon.
Thanks. Bye.
Bye.